Hello everybody. Today we are going to discuss about 2025 ESVM guidelines on the interventional treatment of venous thromboembolism. So there are lots of controversy regarding catheter-based therapy of venous thromboembolism like DVT and pulmonary embolism. So let's have a look on this guideline and be clear with when to use catheter-based therapy. So if the patient with the severe symptom due to iliofemoral and iliocaval location of acute DVT, CBT should be considered. So whenever we are thinking of considering catheter-based therapy, then we should involve vascular expert. So it is recommended that interventionalists with the expertise in the endovascular treatment of iliofemoral and iliocaval obstruction are involved in catheter-based therapy of DVT. So for interventional endovascular treatment of acute DVT, the use of catheter-based thrombectomy should be preferred. For endovascular treatment of acute DVT, the use of endovascular ultrasound should be considered to assess the presence of residual iliofemoral and iliocaval obstruction after CBT to guide for the stent placement. If stent placement is required to reduce residual iliofemoral and iliocaval obstruction after CBT of DVT, the use of dedicated venous stent is recommended. In patient undergoing catheter-based therapy with or without stent placement for symptomatic acute iliofemoral and iliocaval DVT, full dose anticoagulation is needed. So after catheter-based therapy of acute DVT with or without stent placement, a regular follow-up including clinical and the duplex sonographic assessment as well as anticoagulation management is recommended. Now let's have a look on the guidelines of the pulmonary embolism. If we are planning to consider the catheter-based therapy in acute pulmonary embolism, then we should implement the pulmonary embolism response team. The involvement of vascular expert is necessary before if we are planning to consider catheter-based therapy. So it is recommended that interventionalists with the expertise in endovascular treatment of PE is involved in the CBT of PE. So it is also recommended that catheter-based therapy of pulmonary embolism is performed in center with possibility of hemodynamic, respiratory, and circulatory support. So if our patient is diagnosed with intermediate high risk PE, then we should initiate anticoagulation. And if the patient is not responding to the anticoagulation, then we should go for the catheter-based therapy within 24 hours. So if our patient is falling in the category of the high risk PE and if systemic thrombolysis is contraindicated or if it is failed, then consider catheter-based therapy. Unfractionated, if we are planning to go for catheter-based therapy, then the unfractionated weight heparin is the anticoagulation of choice. So after catheter-based therapy, the clinical follow-up is recommended, including electrographic, duplex sonographic assessment, as well as anticoagulation management. Now the recommendation for insertion of the IVC filter. So routine implementation of IVC filter in patient diagnosed with pulmonary embolism and DVT is not recommended. So the placement of IVC filter may be considered in patient with pulmonary embolism and progression of the DVT or PE despite therapeutic dose of anticoagulation. So placement of IVC filter may be considered in patient with acute proximal DVT or PE, those who have the contraindication to the therapeutic dose of anticoagulation. Involvement of vascular expert in decision-making process on implementation of IVC filter is recommended. So this is the summary chart of catheter-based therapy of use of catheter-based therapy in PE. So whenever we are diagnosing any patient with the diagnosis of pulmonary embolism, then the first thing that we are the first thing of the treatment line is to start with anticoagulation. And then we need to divide the patient into three categories, that is high risk PE, intermediate risk PE, and the low risk PE. Again, this intermediate risk P is again divided into intermediate low risk and the intermediate high risk P. So if our patient is falling into the category of the intermediate low risk P, then the interventional treatment of the pulmonary embolism is not indicated. But in case of the intermediate high risk P, we need to activate the PERT therapy, and then we need to start with the unfractionated weight heparin. So if our patient is not responding to the unfractionated weight heparin, then for within 20, we need to wait for 24 hours, and then we need to take the decision of uh, treating patient with catheter based therapy. In case of high risk P, we need to consider treatment with the systemic thrombolysis. But if our systemic thrombolysis is contraindicated, and if it is failed, then we need to consider for the catheter based therapy. And after initiating catheter based therapy, we need to do the regular follow up with echocardiography, duplex sonography, and anticoagulation. Thank you, guys.